Thank you so much, Chelsea, and welcome everybody. Really happy to have you for this webinar about integrative treatment for trauma and complex PTSD with Dr. Arielle Schwartz from the Center for Resilience-Informed Therapy. She comes brilliantly recommended to us. We're very excited. Maybe, Arielle, if you could advance to the next slide.
I sure will.
This is part of the National Training and Technical Assistance Network for Children's Behavioral Health, Clinical High Risk and Early Psychosis Learning Community. I am sad to say that this is the last webinar for this learning community because NTAC, which has been operating for many years, is going to be going out of existence. So it's very sad, but we do encourage everyone to join PEPNet if you haven't already. And there's a vibrant community going on there that where we'll be continuing these kinds of opportunities. This particular presentation is funded by the Substance Abuse and Mental Health Services Administration, and definitely want to give a good shout out to the University of Maryland that's been coordinating this network for all these years, and to thank them for their amazing work. There will be a recording available and an evaluation at the end, so please be sure to fill out the evaluation. And with that, I'm going to hand it over to Arielle. Thank you again so much for joining us. And maybe if you could introduce yourself a little bit more robustly than I just did, that would be great. Thank you.
Thank you, Tamara. Well, it's really a pleasure to be here with all of you and to have an opportunity to be part of this series and to close out this series. I feel really honored about that. And I just want to give a shout out to my friend Katie Hayden-Lewis out in Oregon, who is the one that invited me to be here with you, and I know she's here today. So a little bit more about me and my background. I am a trauma specialist here in Boulder, Colorado, and I have been oriented toward this population, specifically individuals who experienced abuse and neglect in childhood. And that's been my primary orientation for about 15 years or so. And one other kind of core orientation for me in my background that I'd like you to know about is that I'm an integrative practitioner. So my initial degree, my initial entry into this field was through somatic psychology, which is a body-centered psychotherapy. And I brought in and I bring in with me, I'm also a certified yoga instructor, and I teach trauma-informed yoga classes here in Boulder right now online with COVID. And also in the early 2000s, so I trained in somatic psychology in the late 1990s. In the early 2000s, I was trained in EMDR, and that's another kind of very informative piece in terms of how I work. So this integrative mind-body treatment model is what I hope to share with you today, specifically is related to working with trauma and looking at the prevalence of trauma in psychiatric populations. So what you just learned about me in terms of my background is that I'm much more of a trauma and resilience-focused practitioner. I have less experience than most of you here in working with psychiatric populations. So my hope is that we can use our chat exchange here as a communication together. There are going to be materials that I am really grateful to be able to share with you from my perspective, and there's going to be perspectives that you have that I would really hope that you'll add into the conversation. There's something important about us being live together, that we can make it interactive. And even though I can't see your faces or hear your voices, our chat really helps to keep us connected. A little bit more about some of the objectives of what I hope to cover in the time that we have today is to also look at differential diagnosis, looking at what might acute traumatic stress look like, and PTSD or complex PTSD, and how do we differentiate this between other sometimes comorbid disorders, or differential diagnosis between maybe bipolar and trauma, or psychosis and trauma. And we'll also look at the trauma-informed assessment and case conceptualization. How are we holding our clients within the context of their social history, their cultural history, and all of the dynamics that informs who they are in the world, so that we're not just looking through a diagnostic lens, but we're looking through the humanistic lens. We're looking at the whole person within that context. And that context includes us, right? So that when we're being present with another person, what we're observing is their presence in the context of us. And so a huge part of what we want to kind of hold in this is, what are we bringing into the room? Who are we? And we'll explore how that fits into this integrative model today. And we'll also look at what is the rationale for this integrative model. So let's dive in. And I'm enjoying seeing the comments that are coming in, several of you from Oregon, but also from Fairfax, Virginia, and New Jersey, and really all over the country. So it's lovely, and please keep using our chat box to let me know who you are and where you are, and also as if there's pieces that you really feel strongly, whether there's questions that come in along the way or something that you feel like would be a contribution to the conversation, please use our chat box together. So I'm going to dive right into talking about acute traumatic stress. And here we are living in a time that's evoking some stress for quite a lot of people. There is both the experience of the coronavirus, the COVID, the shelter in place and quarantine and reduced social connections, more isolation, all of that. I'm just kind of holding this in our current context, although we'll broaden it out as well. And then also with Black Lives Matter, there's been a lot of important unrest, important coming forward and speaking out and recognizing the need for change. And I'm certainly experiencing that both of those conjoint factors are impacting the individuals whose lives I'm serving right now. And I imagine you're seeing something similar. So it's relevant to this particular piece of what does acute traumatic stress look like? The first thing I want to say about acute traumatic stress is that it's normal, right? That even in the upcoming ICD-11, which is coming out in 2021, I believe, is coming into effect, they have moved it from the mental disorder section into the factors influencing health. Basically, they're depathologizing emotional distress after trauma exposure. And what we recognize is that the feelings of irritability or agitation, anger, fear, panic, sadness, they're all expected experiences after something that's unexpected, right? They're normal after an event that doesn't feel normal. And if we look at what contributes to a traumatic event, we're looking at something that impairs our sense of safety. It feels like a threat to our safety. We have that, right? We have an experience of it's overwhelming our stress response systems. It's overwhelming our coping mechanisms. We have that. Trauma contributes to a sense of isolation. Well, that's happening now. And it also is, influencing a sense of it's challenging our expectations. It's taking us out of what we expected life to be. So, for example, if you expected that you were going on a family vacation this summer, if you expected that school or graduation was going to happen as normal, and I'm just holding this as relevance to COVID right now, all of our expectations have been changed. So again, I want to repeat that the four conditions of something that's traumatic is that it threatens our sense of safety, it overwhelms our coping systems, it contributes to a sense of isolation, and it violates our sense of expectations. So when that happens, again, it's normal to have all of these feelings arise. And in the body, it's also normal to have somatic experiences, numbness, shakiness, nausea, dizziness, right? And when we see that and when we can normalize that, it helps someone else feel more okay with something that doesn't feel okay, right? Because I think so often, even someone that doesn't have a risk factor of psychosis, when they're starting to feel this or have difficulty sleeping or nightmares or the shakiness, they can start to go, oh no, there's something wrong with me, right? I'm going crazy, I'm not normal, right? And those thoughts can further fuel a compounding or a contraction around these states of being, the states of mind, the emotional states. So as we broaden out and that we ourselves become comfortable being present with these experiences, both within our own body, that we have a wider capacity to handle these states of mind and states of emotion, that we also bring that quality of presence to the people with whose lives we're interacting with, right? And that it's a quality of, we call it, regulation or social nervous system from a polyvagal perspective, which I'll speak a little bit about today, that we can actually kind of bring a calmness and a quality to connect in the midst of intensity. And that is a powerful antidote to stress, isn't it? That feeling of we can still be connected, and that through someone else's capacity to kind of hold all of that with some equanimity, with some kindness, that we are better able to hold ourselves. And in the midst of interacting with our people, whether you're working with someone who's at high risk for psychosis or is in a transition phase in their lives, maybe late teens, early 20s, and they're experiencing all of this, that as we come forward and bring that ground of safety, that's right there an interactional trauma-informed care. It's a resilience model right there that we bring forward our capacity to hold and to be present with. So as we recognize that not everyone has that experience of being supported, of the presence of another person, and as a result, these physiological and psychological effects of trauma exposure can persist. And when they continue beyond a month or so, then we start to look at the presence of post-traumatic stress. And here, there might be more re-experiencing symptoms, intrusive memories, intrusive sensations. There can be avoidance of reminders of the trauma, not wanting to go back out in the world. If any of you are working with individuals who've had a predisposition or a propensity towards OCD, that, the avoidance behaviors have gotten amplified for many individuals during this time because they are they're fueled by this fear of going out into the world, right? And if we're looking at other types of traumatic events outside of the context of COVID, if someone has experienced trauma in their household, maybe domestic violence, or maybe they experienced a fire, a flood, right? This avoidance of reminders of the trauma can lead to withdrawal, can further that sense of isolation, can lead individuals to engage in behaviors that foster avoidance, such as drinking or using drugs, substance use, or sometimes, emotional eating, not wanting to reach out and connect to people, all of these behaviors to basically not have to touch the re-experiencing symptoms, the intrusive memories and sensations. And that the third category of symptoms with PTSD is this heightened sense of threat and arousal, a hypervigilance to our surroundings, maybe nightmares, experience of a high startle, a high reactivity. And the most important piece is that PTSD occurs when we don't have the resources to support the process that arises during the acute trauma exposure. The resources can really come down to having one person that's invested in supporting the individual, supporting us. Okay? The research, especially around resilience to traumatic stress in children, is that the presence of one individual, one adult who takes a healthy interest in that child's inner world, in their emotional experience, in their processing of what's happening around them, that provides that support, is a buffer against the development of complex PTSD, of traumatic stress. And it's true across all ages that when we don't have support and the resources to process what happened, it can lead to overwhelm and shutting down. So what I was just speaking about were PTSD symptoms that happen in hyperarousal or a high arousal state: anxiety, panic, the nightmares, the flashbacks, the hypervigilance. But it's important to know that there's also a dissociative subtype of PTSD. And here, this is often linked to high severity trauma exposure, and it's marked by a predominance of derealization and depersonalization symptoms. What this means is that the individual might feel disconnected from their body. The body doesn't feel like their own. The world doesn't seem real, right? That's surreality. And times that they might feel like they're in a daze or a fog. Now, these aren't medication-induced symptoms. These are symptoms that are induced by the neurobiology of trauma, the neurophysiology. When a predominant dissociative response occurs, the body is actually releasing neurochemicals that lead to this disoriented feeling. There's actually a flooding of numbing chemicals, of natural opiates in the body that actually reduce our capacity to feel pain. It serves as a survival mechanism in the face of a life-threatening event. But when this experience is ongoing and it's fueled by an internal response system, it can actually lead someone to not be able to feel their body. If they look down, the body looks and feels foreign. Right? And that also there can be more difficulty with memory in this dissociative subtype. And so the coherence of mind is impaired. And if you look at this and you're starting to think, well, this starts to look and sound a bit like psychosis or early presentation, you're right. And to recognize that these types of symptoms can arise as a result of trauma is a really key component in understanding and starting to look at this differential diagnosis. One other category of PTSD that's worth discussing here is complex PTSD. And complex PTSD can arise when the trauma itself is repeated, chronic, ongoing. Most often, complex PTSD arises as a result of interpersonal trauma, in the experience of a deep betrayal in relationship to other human beings. So this adds in 3 additional criteria in addition to the high arousal re-experiencing symptoms and avoidance symptoms. And these 3 additional criteria are difficulties with affect regulation, disturbance with self-organization or problems with self-concept, and interpersonal problems. So we might see individuals who are much more labile in their emotions. They have much more difficulty managing anger, irritability, hopelessness, despair, and those emotions can range from those very hyper-aroused emotions to hypo-aroused depression to racing mind, right? It can mimic bipolar. And the symptoms of self-organization and problems with self-concept can be very strongly interfering negative thinking patterns of often around self being bad or at fault or responsible for bad things. And the interpersonal problems, all of this leading to struggles with our relationships, especially when there's been a deep relational betrayal, right? This experience in which I can't trust other humans. Okay, I'm going to take a look here at the chat box. So the question is from Katie, what do you know about the higher rate of severe diagnostic labels for the Black, Indigenous, and people of color that misses the need to address systemic racism and instead treats individuals as if they developed symptoms in a social vacuum? And what can we do differently? This is a fantastic question. It's actually been on my mind so much in the past month. I think it's been on a lot of our minds with, after the death of George Floyd and the experience of now we're so much more aware. It's not that these incidents haven't been happening for centuries, but we're now really being asked to look at the systemized racism that lives in our culture and really in our world, but certainly in this country. And so, absolutely, we cannot look at an individual within a social vacuum, within just their symptoms. We have to hold that context. And, when I was mentioning before that this is a model of mutuality, it's a model of really looking at our own participation. I believe this question of what can we do differently is that one layer is that it starts here. It starts with our own curiosity of how are we showing up in the presence of another individual, and how are their symptoms related not only to our interactions, but that all symptoms are a reflection of our interactions with our world, whether that is the experience of events that happened in one's childhood home, or the ongoing chronic experience of feeling different or discriminated against, or not welcome in your community, or not safe in your community, not safe to drive down the street, right? And the vigilance in terms of complex PTSD that creates over time. And this is not just a mind experience, it's an embodied experience. It's a chronic state of not being safe. And when we have that chronic experience of the nervous system basically stuck in a sympathetic fight-flight state, well, first of all, we can only accommodate that for so long. And then there's a breakdown in our physiology as a result of chronic stress. And I think that the piece about complex PTSD is that sometimes it can be hard to diagnose because we're always looking for the initial criteria for PTSD, which is the single traumatic event. And what we need to hold, especially in the context of your question, Katie, is that sometimes there isn't a single traumatic event. What we're looking at is the accumulation of events that happened across a lifetime or across a childhood, or going to school and no one's sitting with you at the table, and walking down the street and feeling paranoid, and inappropriate paranoia, right? So we need to hold all of those contexts in this. So thank you, and feel free to contribute to my answer to these questions. I think that we're all in this conversation together. So thank you. I appreciate that. So let's look a little bit more deeply at how complex PTSD can arise in different contexts. So we'll start here with developmental trauma. And I'm going to bring in a quote from Julian Ford and Christine Courtois, their book, Treating Complex Traumatic Stress Disorders, and I actually have it under my computer. And if you'll excuse the movement of my computer for a moment, I'm going to pull it out and hold it up because it's such a book worth knowing about. I pile my computer for height reasons on my books, but this one here, this Treating Complex Traumatic Stress Disorders, a brilliant book. And if there's something that you want to have on your bookshelf to really help you be more trauma informed, I have the the reference here on this slide, as well as in your references at the end of these slides. So it's really worth having. And what they describe is that the adverse interpersonal childhood traumas leads to breakdowns in the psychobiology of the child. As a result, we begin to see a lack of integrity in the body and mind relationship, interference in the formation of a coherent identity, and disruptions in attachment, impairing the development of healthy and reciprocal relationships. All right, that's a mouthful. I want to break down just a little bit of this slide, which is when it says here, we see a lack of integrity in the body-mind relationship. This is huge. In early childhood, and this is, we're going to say all the way back to the attachment phase, to infancy, that what facilitates integrity in the body-mind relationship is attunement in the family system, attunement from the primary attachment caregiver. And that what attunement can look like is really being able to listen to and read and respond to the nonverbal signals of the infant. The infant's not going to tell you with words, I'm hungry, I'm thirsty, I'm tired, right? But that the attuned caregiver is tracking and is not only tracking the other, but how do we know what the other is feeling? But it's a reciprocal relationship, so we track ourselves. And we feel a sensation in here, and we're responding to a sensation out there. And the more that the primary caregiver is congruent with their own body and mind and emotions, the safer it feels for other. And I'm aware that in the work with early psychosis, that a big contributing factor is that lack of congruence, is the unexpressed emotions, is the disorganized experience when a parent is saying one thing, but their face is showing something else, right? And it starts in infancy, and it goes as we continue to develop and have our language capacities. That those incongruencies become more disturbing, more dysregulating for the child. And as a result, when we have to belong for our very survival, we need to feel attached and connected to other, we have to abandon our own knowing, our embodied truth of the felt experience for the sake of attaching to another person. So I'll give an example here. A friend of mine who's a grandfather, his grandchild came up to him and he said, "Grandpa, why are you so angry?" And he says, "I'm not angry." Well, what does the child say? Brilliantly, he says, "Well, tell that to your face," right? Because the child sees and knows. And in this case, it was a lovely example because he went, "Oh, well, maybe I am," right? He did a self-check. He received the feedback from his grandson and said, "Oh," right? And obviously the grandson felt safe enough to say, tell that to your face, right? Like there's something going on here. Children are primarily right-brained. And what that means is that they're much more likely to pick up on the subtle emotional nuances, the facial expressions, the voice tone, the body language of the adults in their lives. And when there's those incongruencies, again, it's disorganizing. But in a childhood home where there's abuse that's happening, or where there's neglect that's happening, there is this disjointed experience of, I need these people to survive. I have an innate attachment system that leads me to need to attach to them. And yet there is an internal system that's saying, flight, fight, get out of here. The sympathetic nervous system is keyed up in a feeling of lack of safety. And so in order to survive this, in order to keep the attachment systems intact, they have to dissociate from the other somatic experience or have some other way to cope with that. So this interferes with that integrity of the body-mind relationship and the interference in the formation of coherent identity. Who am I in the world? And especially when that's not getting reflected to us, when we're not getting a feedback loop system that's accurate, right? So that when I have a feeling, sadness, anger, fear, and the attuned parent comes and says, I see you look sad right now, or you look afraid right now. And then we go, oh, that's what that is. That's that feeling. It matches the felt experience in the body, and we have a sync up of coherence. And when that's missing, or when experiences get mislabeled, or when there's profound neglect and we have no feedback system, we see individuals who cannot recognize their own emotions. There's alexithymia in the mix. They can't identify a felt experience that matches the emotional experience or how it fits in that social context. So all of this we're talking about in the early developmental trauma. Let's take a look at what happens in other situational traumas. So here, for example, some research on refugees who were diagnosed with complex PTSD. They may not have had the early developmental deficits, but have had equally damaging experiences of relationships with others, so as to catastrophically change their view of themselves and other people in the wider world, right? So this deep experience of my trust in the world and my trust in myself and who I am and what I know to be true, so going back to racialized trauma, this is quite relevant there as well, especially when there has been an ongoing chronic feeling of betrayal from your own country or from the people that are supposed to protect you. Individuals with, again, this is referring to a refugee population, individuals experience mental defeat, a state of giving up in one's own mind all efforts to retain one's identity as a human being with a will of one's own. That experience of the accumulation of helplessness, that nothing I do will make a difference. There's a futility that goes along with this. And the accumulation of what Martin Seligman speaks about as learned helplessness, that if nothing I do is going to make a difference, I can't change the system, or I can't get out of a hostage situation, or I can't get out of a cage, or I can't get back connected to my parents, right? Things that are real that happen in our world, there is a point at which this mental defeat can take over. So let's take a look at prevalence. The traumatic event exposure in a national sample of U.S. adults, and this is almost 3,000 individuals, was upwards of close to 90% of individuals who reported at least one traumatic event across their lifetime. And exposure to multiple traumatic events is the norm. So this is so significant, and I don't think it's a surprise. I mean, here we are in a collective pandemic. We're in to some degree, a collective trauma experience right now. But, add into it all of the types of traumatic events that can happen, everything from a car accident to a flood to a fire to incidents in the home and in the community, right, a school shooting. So we're recognizing that more and more people will be exposed to something. Now, being exposed to a traumatic event does not mean that one will develop PTSD. We want to be very clear about that. However, despite being highly prevalent, post-traumatic stress disorder is surprisingly underdiagnosed. And looking at a mental health population, and this, I was looking for a U.S. study on this. I could not find one in the U.S. This study is out of Brazil, but it really was quite striking. And again, it had a very large sample size. And in this one, this one was from Brazil, that they had found that only 8% of the mental health population received a diagnosis of PTSD. And as far as I'm looking at my references here, this also came from the U.S. study. So excuse me, this is in both. That I think I combined the results of the two, and it came out to about 8% of our mental health population receives a diagnosis of PTSD. However, 90% are reporting exposure to traumatic events. And no surprise here that post-traumatic stress disorder rates, PTSD rates, are higher among the U.S. Latinos, African Americans, American Indians, and lower rates were found in Caucasian and Asian Americans. So we are looking at this discrepancy between how many people are exposed to trauma and how many receive a diagnosis. A large proportion of patients receiving mental health services with other non-PTSD primary diagnoses are meeting criteria for PTSD, but there's no record of it in the patient's clinical records. And that's a really significant piece right here. So that we are seeing that there's actually much more likelihood that people are actually meeting full criteria for PTSD, but there's no record in the clinical records. And the prevalence of mental health patients who screened positive for PTSD who had not previously been diagnosed was another 14%. So this study came out of the U.S. This is in depression and anxiety, and they looked at approximately 2,000 individuals who did not have a PTSD diagnosis, and they ran them through the screening criteria for PTSD and found 14% of individuals rated positive for PTSD, but they had not had that in their clinical record. On top of that, another study was looking at the percentage of individuals who meet the subthreshold PTSD. And among those individuals, there was there was a significant percentage of patients who met that criteria. They didn't meet full criteria for PTSD, but they reported impaired social and occupational functioning, and 73% desired treatment for symptoms. So even if we are working with someone who does not meet full criteria for PTSD, many will have some of the criteria and certainly would benefit from treatment. Now, I'm aware that in the programs treating early onset psychosis, that trauma has traditionally been a rule out for the program, and but we also recognize that there is this kind of vicious cycle that happens in which individuals who are exposed to early trauma are at greater risk for PTSD, and on top of that, the experience of psychosis can itself be traumatic. And the diagnosis and the medical interventions and medications and whatever the symptoms themselves are. So we need to really keep in mind how incredibly prevalent PTSD is in this population. That's helpful to know, Ryan. Thank you. So Ryan writes, trauma itself is not a rule out for ESA. So thank you. I appreciate that. So looking at differential diagnosis and comorbidity, we have a whole range of diagnoses that can be a result of trauma. Trauma can mimic these different disorders, and they can be comorbid, right? Major depressive disorder, that hypoaroused predominance of symptoms. Bipolar disorder, individuals who oscillate between hyperarousal and hypoarousal. Generalized anxiety, panic disorder, obsessive compulsive, right? Ways to manage or avoid symptoms. Learning disabilities. There is a particular cycle, a correlation in relationship to learning disabilities and ADHD with childhood trauma. Individuals who are traumatized as children have a greater likelihood to develop learning disabilities and ADHD. And individuals who are born with learning disabilities and ADHD are more likely to be abused because their symptoms can trigger parents, either impulsivity or the hyperactivity of these children can be trigger factors for parents who can't manage their own reactivity and emotions. So Dee writes in, why is there such a disconnect here? I feel like all of this fits with my son who experienced deep chronic trauma from a chronic medical condition. He was later diagnosed bipolar, but this was never even discussed from a mental health or medical professionals. I'm assuming you're saying that his deep chronic trauma was never discussed as a factor of his bipolar. And I do think it is such a disconnect, Dee. I just think it's an incredibly painful fact that there is a lack of trauma-informed care in our medical systems, in our police systems, and in a lot of places. And so it's very much my driving factor here and why I give these presentations. Thank you for that. And why is there such a disconnect? I don't think people get trained in this, and I think that there's been a huge blind spot around trauma. Clearly there's a huge trauma component for a lot of individuals with substance abuse histories or addictions, and personality disorders, especially borderline and narcissistic, have a very strong correlation with early childhood trauma. As we spoke about before, PTSD and dissociative subtype, a lot of crossover between the dissociative identity disorder or dissociative disorder not otherwise specified, and conversion disorders. The likelihood that individuals will somaticize or experience in their bodies, either through illness or through somatic symptom disorders, psychogenic seizures, migraines, and so forth, can be manifestations of trauma. And then also the schizophrenia spectrum and other psychotic disorders. And we'll take a closer look at that one on this next slide. So here, what we're looking at is that childhood trauma and current PTSD are statistically significant predictors of the onset of psychotic disorders, with an almost threefold increased risk. Individuals with hallucinations and delusions more frequently experience traumas during childhood, and sexually abused youth were nearly 10 times more likely to develop a psychotic disorder than non-abused youth. So clearly there's a massive correlation. And, my hope is that we can support you here to be more trauma-informed in your work in the world, so that you're really listening and attuning to the potential early trauma experiences of individuals whom you serve. So when we're looking at the etiology of PTSD or complex PTSD, we might be looking at single incident events, we might be looking at child abuse or neglect, disrupted attachment, domestic violence, either experiencing or witnessing of this, ongoing social stress, homelessness, bullying. We can put in here as well systemic racism, right? Community and political violence, refugee situations, prolonged captivity. And if you are not familiar with the Adverse Childhood Experiences study, you will be now, and there is so much out there. This was a massive, large-scale study that was looking at the relationship between early childhood adverse experiences, this list here on the right, and the mental health and physical health correlations with these events. The study started out by trying to understand obesity. One of the key researchers, Vincent Folletti, had been doing a study on obesity, and he had a particular patient who had lost a tremendous amount of weight, more than 50 or 60 pounds, and in the longitudinal follow-up, she had put all of the weight back on. And in a conversation with her, he said, "What happened?" And she said, "I didn't feel safe in the world without the weight that was protecting me." And then he learned about her childhood trauma history, and a light bulb went off. And he said, "I want to understand more of this. I want to understand more of this connection." And this study showed an undeniable correlation between childhood events with these physical health, mental health, substance abuse problems in adulthood. Suicidality was a much greater factor. Depression was a greater factor. Anxiety, as well as physical health conditions, including heart disease and obesity and lung disease and greater incidence of skeletal fractures. So there was this massive correlation, and it kind of woke us up. But what we know is that we also have to look beyond the ACEs. We have to look at additional hidden factors in PTSD, hidden factors like pre- and perinatal trauma. What we know now is that the amygdala, the part of the brain involved in our implicit memory system, is online in the 3rd trimester of pregnancy. And so we develop implicit felt sense memories, experiences of our world, and that these really early preverbal traumas shape our vagus nerve, our vagal tone. It impacts our response to stress. Children who in utero were exposed to stress are born with a more prone to colic, are born with more vulnerable stress response systems. This is the work of Rachel Yehuda. She's the 3rd reference down here. And she did a study that was following, it's actually a different reference of hers, but she was following women who were pregnant and experienced PTSD during 9/11, and that their children had lower birth rates, higher colic rates, struggled with sleep, had all of these very vulnerable stress response systems as a result of that pregnancy trauma. And this continues into early attachment, right? Bessel van der Kolk, in his book, The Body Keeps the Score, looks so much at these early preverbal attachment traumas and how they inform our sense of self, our sense of identity. The preverbal and nonverbal traumas are, they are often not totally remembered because our explicit memory systems aren't online yet. So it's much more of a felt sense in the body. And I think that's a really key piece, that now what we're looking at is a trauma response that's invisible, that's happening from an internal felt experience, a set of memories that we don't even know what they're connected to, but we're reacting to them. And it can actually feel unsafe to be in one's own body, right? Sometimes these hidden factors happened in the generation that preceded us or several generations back. When we look at the influence in our indigenous cultures of the violence that happened there, when we look at post-traumatic slave syndrome, when we look at Holocaust trauma, we can see the influence of these transgenerational traumas, and it shows up in the epigenetics. So here, Rachel Yehuda's work, again, is looking at the vulnerable stress response systems and recognizing that children whose parents had PTSD are more likely to develop PTSD when exposed to a trauma as compared to children whose parents didn't have PTSD. So it's a predisposition to a more vulnerable stress response system. And the presence of a learning disability I spoke about earlier, the lack of resilience factors, the lack of that one supportive individual who helps us process our world. So here's a whole list, which I'm not going to take the time right now to read every bullet point, but just pieces to keep in mind when you're meeting with your individuals as to what might be additional contributors to a trauma response. Right? Were they exposed to a mother who had postpartum depression? Was there an extended separation after birth due to medical cause? Were there adoption-related concerns? Was there early neglect? Right? Was there an experience of rejection by mother or father? Were they wanted at pregnancy? Right? And again, I won't go through all of these, but even something as subtle as chronically feeling not understood in your family can create a stress response, right? So what are the goals of treatment? We want to increase our individuals' capacity, the people who we serve, their capacity to be present with and effectively respond to or regulate states of mind, emotions, sensations, and interpersonal exchanges. From the perspective of interpersonal neurobiology, we look at the window of tolerance, which is basically what emotions and sensations and thoughts can the individual stay present with and effectively respond to. That's what lives inside of our window of tolerance. And what states of mind, emotional experiences, physiological experiences are outliers, are outside of that, are dysregulating for us. And they fall in the hyperarousal continuum, on that in red on the left picture there, or the hypoarousal continuum. And excuse me, you can't read the words there, too small. But it's talking about how in the upper side of that continuum, it says it's the sympathetic nervous system, our fight-flight response, anxiety, panic, or hypervigilance. But when we can't respond, when it's outside of our window of tolerance, it's dysregulating. In the blue on the right there, those are hypoarousal symptoms associated with a evolutionarily old part of the parasympathetic nervous system, the vagus nerve, that drops into a dorsal vagal state associated with depression and despair and hopelessness and I can't even read dissociation. I was going to say, I can't read the last word there. So what our goal of treatment is to recognize when clients are outside of their window of tolerance. Sometimes they're more prone to hyperarousal or hypoarousal. Sometimes they alternate between the two. Again, it can look like bipolar. And that our well-paced therapy helps clients build distress tolerance. They work the just tolerable edges of the sensation, the discomfort, and they build that capacity to be with. And how do we build that? We build it through co-regulation. We build it through relationship. When someone else can be with our distress and not be afraid and not be dysregulated by it, it teaches us how to do that for ourselves. So in trauma treatment, we look typically, and this comes from the work of Judith Herman and her seminal work on trauma and recovery, at 3 stages of treatment. The first stage is to establish stability and safety. The second stage is to help individuals process traumatic material in that well-paced manner, growing the window of tolerance at a pace that's manageable. And the third stage is reintegration of our experience, a new experience of ourself, right? Like we have an experience with another person and we're able to handle that frightening memory and we have a new sense of our strength, and then we have to integrate that into our sense of identity. So let's see, there's a question that came in here from Andrea. I attended a polyvagal trauma training a while back, and the trainer mentioned how one can experience trauma from medical procedures even though the individual is not aware, I'm assuming you're saying, of the procedure under anesthesia. I'm curious as to what your thoughts are on this and how to help someone with trauma symptoms even if they don't have memory of the trauma. I'm translating your question a little bit, but absolutely. So when we're working with the nonverbal trauma, the felt sense, the somatic experience, and in fact, I think I'm going to get to the answer of your question, Andrea, on an upcoming slide here. We have to go toward where the body keeps the score. We have to work in a somatic approach. We don't even have to know exactly what happened in order to work with the somatic experience, but we can build that distress tolerance, that sensation tolerance, the ability to compassionately hold our experience. We have imaginal capacities to imagine ourselves in the medical procedure and how that might have impacted us, and hold compassion for that part of us that experienced it, even if we don't directly remember it from here, because we remember it in either a felt experience or we remember it as a dysregulating emotion, and we can work with that. So this really comes into this next slide. It was a perfect segue, Andrea. That the integrative treatment for trauma and complex PTSD involves 6 components, and this is really the 6 factors that I bring into all of my books. I'm the author right now of 4 books, and I have a 5th book that I turn in next Wednesday, which I'm really excited about, and it's really this integrative treatment model for practitioners. And that the integrative treatment model starts with our therapeutic relationship. It starts with our relationship with the other person, whether it's your own child, whether it is a client of yours, whether it is a friend. It starts with relationship. And from a therapeutic perspective, this brings in psychodynamic or interpersonal or relational therapy, relational therapy or relational cultural therapy has had a huge influence on me. It's always including the social cultural context that the individual experiences as well as their developmental context. So we're looking at our history of relational experiences and how does that inform our sense of self. We internalize the relationships that we experience with others. And but what's so powerful is that even if we had a disorganized attachment experience with a primary caregiver, or if we experienced early relational abuse in the home, or were exposed to domestic violence, even if that informs our early relational experience and sense of self, we can still grow through healthy relationships all the way through the lifespan. So when we relate to other people that are co-regulating with us and bring authenticity and mutuality, that it helps us redevelop a sense of trust and capacity for others. And that experience of co-regulation when someone else is coming with our own capacity, our own widened window of tolerance, our capacity to be present with that much emotion and distress, and brings that presence that our social nervous system, our capacity to be regulated, indirectly informs the other person and directly gives them experience of being compassionately understood, being accepted for who they are. And through that, it wires the internal system to say, I know what this feels like, and now I can start to do this for me, and I can start to do it for others. So it builds in so many levels. Now, I want to say something about the mindfulness-based therapies here. I want to be very clear that especially for a psychosis community, for an individual experiencing those symptoms, I'm not going to go out there and teach meditation. Right? But what I mean by integrating mindfulness-based work into the integrative model is that we are being mindfully present to our own experience. We're working in the present moment. We're bringing curiosity to the present moment and non-judgment. We are building distress tolerance by staying with sensation and staying curious. So I mentioned that, my primary wheelhouse is not working with psychosis, but as many of us have had experiences, one of my very early internships in this field was working with in a home-based model for psychotic clients. And it was in a Windhorse model, and some of you may or may not be familiar with this. Because I studied somatic psychology here in Boulder at Naropa University, the Windhorse model was developed by Ed Podval, who is one of the founding individuals for Naropa. And this model really speaks to the importance of the team that surrounds an individual who's experiencing psychosis being able to regulate ourselves through some kind of mindfulness practice, whether that's meditation or yoga, but something that builds our own mindful body awareness and metacognition, mindfulness of mind. And when we have that capacity to regulate ourselves, what we're doing when we're interacting with another is we are offering that tone of our nervous system to be shared in the form of co-regulation. So we can see how these different factors relate to each other. Parts work therapy basically is understanding that individuals who experience trauma, especially childhood trauma, can develop a structural dissociation, or basically a fracture within self, a split within self, sometimes between the part of self that needs to uphold that attachment system and disconnect or dissociate from the fear-based system related to abuse. Or there can be different ego states. A critical parent gets internalized as that self-critical voice, right? And from an IFS, or an internal family systems perspective, we recognize that we hold all of this as internal parts of self. They're part of our identity, these parts that maybe get exiled off, the parts that hold the trauma that we don't want to relate to, and that what we build is our capacity to be that self that can turn toward all of our experiences and our states of mind, which are really what parts are, is states of mind and states of emotion, and we can hold more. We build greater capacity for the self to hold more of all of us, right? In the fourth component here, reprocessing of traumatic memories, there's actually some really good evidence out there, and I apologize, I don't have this reference on our slide here, but there's some good evidence of the efficacy of EMDR with individuals with schizophrenia. It's not contraindicated, but what I would say after having been in the EMDR field for 19 years is that you need to modify the protocol. You need to work slowly with someone who's in a very fragile mental and emotional state, and that what we want to do is actually work with a modified protocol that lets us touch just the edge of that window of tolerance, the edge of the discomfort, and then come back to an orienting to safety. And then we pendulate between those two places at a pace that the individual can tolerate. And Edgar writes in, I'm wondering if you can touch on stress during pregnancy and womb trauma. And I'm reading that here because it's a lovely segue to this next, to number 5 here, which is somatic therapies. To me, we're not going to be able to work with that prenatal trauma or womb trauma if we don't go towards the body. And what somatic therapies help us do is basically tune into what are the stuck experiences in the body. Where has the body contracted around trauma? And from a felt sense perspective, be able to integrate subtle movement or breath practices that help us resolve that experience. So I'll start with one that's not pregnancy-related trauma, but perhaps the experience of abuse during childhood, in which a child couldn't flee and couldn't fight against an adult who was abusing them. In the body, what gets truncated is that they couldn't ever push or run away, right? What got patterned in is a collapse and a helplessness from a somatic perspective. And so the somatic therapies actually help us reclaim healthy mobilization, and we do it slowly, right? So that we can really just explore what does it feel like to mindfully push through the hands or press into the feet and find that length of the spine, and then go back towards maybe a chronic feeling of collapse, and then explore what it feels like to find a support in the core muscles, and then explore back and forth. Now, when we're working with early prenatal trauma, it's not so different. It's just that we have to use more of our imagination. Maybe you've been told a story about what happened during a mother's pregnancy, and then you work with the story memory. And all of this is discussed in my book on EMDR and somatic psychology. So you can find actually in here, even if you're not an EMDR practitioner, you can find in this book, EMDR and somatic psychology, guidelines for how to work with prenatal and transgenerational traumas. So it's all in there. And the sixth piece here is complementary and alternative medicine, which brings in a treatment team, which can be so helpful sometimes. What if we experience safety for the first time in our lives on a yoga mat, when the teacher says, just let yourself be supported by the floor has your back. If no one's ever had your back, and humans aren't trustworthy, but maybe you can let the floor hold your back, right? Or maybe another person holds your head gently through craniosacral or massage and lets the emotions move through that felt sense of support, right? So we can bring in, or we can look at nutritional deficiencies and how they are can be significant contributors to mental health imbalances, right? Anxiety and depression as food intolerances that maybe were never recognized and are again irritating the system from the inside out, so that there's a fight-flight being triggered by food reactions. So obviously we don't go into this whole model here, because I usually spend 18 hours on this training, but you get a taste of it here. I'll share one last slide, and then I want to open it up for further comments and questions. This last slide are just a few tools that I want to send you out of this webinar with. And the first one I've already been speaking about, it's that co-regulation. It's really knowing that we need to do our oxygen mask first, right? We need to regulate ourselves, breathe, connect to your own capacity to be engaged with your social nervous system. Now, the social nervous system is the most evolved part of our vagus nerve, and it allows us to feel connected and calm and safe within ourselves, and it allows us to connect to others and offer that, that regulation system in an interpersonal format. The second tool, which to me is like what I teach any individual that I'm working with in our first session, is choice and containment. It is basically that we recognize that trauma interferes with our ability to be at choice about when, where, or whether we think about trauma-related memories. And so when we reclaim choice and containment, it's making an agreement with the psyche about when we're going to think about trauma and when we're not, right? I'm not going to think about trauma when I'm trying to parent my children. And for an individual whose cognitive or mental capacities are very loose, there's a flight of ideas, they're having difficulty with this, I make containment very tangible. We create a box, we put the scary thoughts in the box, we put a lid on the box, right? We make it tangible. The only way, however, that containment successfully works is when we have an agreement with the psyche that we have a place that's safe for us to uncontain, to open up the box, to process the scary thoughts and feelings. And that might be in therapy, that might be with, a very safe co-counselor, it might be with a safe friend, but we need to have places where we can open that up and process the deep feelings and know that we can close it when we need to go out and be in the world. We need to go to school and learn. That's not the time to think about trauma, right? Attentional control and orienting are very related to choice and containment. And what attentional control means is that we are developing more choice and control about what we're thinking about and what we're focusing on. Usually what I start with attentional control is an orienting practice, which is basically just being able to look around your space and choose what to look at, and look at items that help you feel calm and safe in the moment, right? So that if there's a piece of art in your office, or you can use essential oils, you can use other senses, you can use the sense of smell, you can use, something that someone can hold in their hands, a rock or a pine cone, right? So just having something through the senses that we can focus on through the external senses that helps us decrease flooding of the interoceptive triggers of trauma that can show up with felt sense in the body. Eventually, we want to work towards helping individuals build more mindful body awareness, but when trauma lives in the body, mindful body awareness can feel really threatening. So we very slowly, you might just start with the fingertips, the toes, the feet, and then grounding into the legs. Right? So that you can just do this with me now, just feel your feet on the ground and press into your feet and just notice how that activates the muscles of your legs. You can focus your attention there rather than feeling all of the emotional chaos, right? So that you can use attentional control in that way. Connecting to breath, another practice here where, especially with trauma, individuals actually usually are over-breathing, over-inhaling. So the most effective calming breath strategy is to exhale to completion, to really just focus on lengthening the exhale in comparison to the inhale. The inhale is the sympathetic nervous system, the exhale is the parasympathetic nervous system. Now for individuals who are more dissociative and stuck in parasympathetic, sometimes the inhale can actually be a little bit more regulating. So we tailor that to the individual. And then the last thing is that, as I was saying before, we have our capacity for imagination. Visualization and guided imagery can help us calm down. It can help us find resource. So if you can remember, and if any of you have ever been with me on Facebook, you know that I share these pictures on my Dr. Arielle Schwartz page pretty much every day. This is my safe place. It's the walk from my house, and it's my peaceful place. I can go there in my mind. I go there, regularly in the real world, and if there's something that's distressing, that's a very calming resource to have someplace in your mind that you can go to, or literally in your physical world, right? To create a safe space in your home that can help you calm down. So I just want to thank you all. I want to open this up. I'm going to let you know that from here on, you have a lot of slides with a lot of references. And so please make use of those. This is how you can get in contact with me. And also my website is drarielleschwartz.com. And if you're on Facebook, you can find me at Dr. Arielle Schwartz. But let's see what you want to talk about. Let's open this up a little bit. Thank you, Ryan. So you may or may not have questions, and that is absolutely fine. Tamara, I'm wondering if we want to just open it up for you and I to chat a little bit too. All right, we have one coming in here. It says, from Katie, can you talk about how folks might approach comorbidity work based on your model, psychosis and PTSD? Absolutely. So, what I would say is that always we're going to start with that first part of the model, which is relationship. And, that if we are, so that if we are looking at what is the individual, what are their symptoms, what are they ready for, right? I'm almost always going to start with that safety and stability first, resourcing the individual. So that if there is psychosis and PTSD, we want to do our very best to stabilize the dysregulating symptoms. And if those dysregulating symptoms are psychosis, what can we do to stabilize those? However, here's always this tricky dance, and we see the same dance with comorbidity with substance use. We see the same dance with any other avoidance behaviors, any other addictions, is that when we have trauma, you can think of trauma as a kind of like what's underneath the volcano. It's a lot of pressure in the system. And until we work through some of the trauma, that pressure is still going to be there. So we can resource all we want, but if we're not really helping someone feel safe to touch into the emotions in relationship, we're not really helping them process through whatever is creating that pressure that's leading to the symptoms that we're seeing on the surface. So I think that once we have that therapeutic relationship and a ground of safety, that we want to just very slowly touch those edges of what I never wanted anyone to know about me is that I'm deeply afraid of, or that I have this haunting memory of. And we start to just touch the edges of the trauma, even if we're not fully reprocessing it with EMDR or somatic psychology, but we're just allowing a little bit of that to come forward. And then we say, now that you've just shared that with me, what are you feeling in your body? And can you just feel your feet on the ground? And can you look around and know that you're safe with me? And those emotions are welcome here. And just let that pressure start to feel like it can be held more than just self in one's own body. It can be held through that co-regulation and mutuality. So hopefully, Katie, that helps with that question. So Amber, you're bringing your question back. So let me make sure that I understood your question. You're asking if I can touch on the way that stress during pregnancy and womb trauma and the effects of that. So if I'm understanding your question better, it's really about that Rachel Yehuda was looking at the impact of stress in the mother's body during pregnancy and that what happens is that chronic high stress is leading to a chronic release of cortisol in the mother's body, and that when that goes unresolved, it can change the hypothalamic pituitary adrenal axis, the HPA axis, which is basically our stress response system between the brain and the body. And so what happens is that it actually impairs or modifies the feedback loop between cortisol and the HPA feedback loop. And then what happens is that children are born with that same modification in their HPA axis. Their mind-body stress response system has also been modified. And this is especially true in her research of transgenerational trauma when a parent had chronic PTSD that was unresolved. And then through pregnancy, that gets passed on to the next generation. And so what she found was that there was an epigenetic change in the infant and later child's stress response system and how their cortisol and HPA axis are functioning. So Amber, let me know if that got to a better answer of your question. Thank you for asking. Roxanne says, what can a family member do besides relationship, one question's come in, it moves, besides relationship-wise to help someone with PTSD? I would say that finding a really good trauma-informed practitioner that knows how to progress slowly and safely, especially if there's comorbid psychosis in addition to the PTSD. So, looking for someone who is informed about complex PTSD in particular. And there's a lot of good people out there. So, to build a team around your child is really what I would say. Let's see, Sarah writes, I'm processing all of that information. I want to do the 18 hours. Thank you. Catherine says, how could integrative treatments vary for individuals seeking treatment immediately after trauma versus waiting years to seek support? I love that question, Catherine. Thank you. So what I would say is that when there's acute trauma, in some ways we have a very prime opportunity to intervene in acute trauma, traumatic stress, because the stress response system has not been habitualized yet. It's not been reinforced, and so it's very raw. It's very ripe for intervention, and so from that standpoint, we can come in and we can safely help them to process the recent traumatic event exposure. And actually, sometimes even that can be a little bit safer for someone who has other comorbid diagnoses to process recent trauma than to process all of the stuff that accumulated over years. So what we do is in a recent traumatic event protocol, for example, is we find what are the peaks of disturbance related to the trauma exposure, and that we just allow them to recall or describe maybe an image related to it, the felt sense in the body related to it. Are there any thoughts or beliefs related to that particular moment of the traumatic incident? And then we allow them to process it. In EMDR, we add bilateral, but it's not necessary. Really what we're doing is attending to and attuning to what are they feeling in the body, what are the emotions, and what are the needs. Is the need to recognize that it's over now? Is the need to recognize that it wasn't my fault? Is the need to feel that I'm connected to someone again, that I'm not isolated, right? So that is the need to feel like I can move my body because I couldn't move my body when that happened. So we check in with what are the needs, and we seek to find repair or completion of whatever didn't get to occur during the traumatic event. And honestly, we do very similar work if we're catching someone years later. It's just that it's not as sometimes it's not as available, but there's a ripeness when the trauma has just occurred. Katie writes, if there's time, what might supervisors include in their supervision work to develop the skills that you've discussed? And is that okay for all levels of educational backgrounds, associate's degree, bachelor's, and so forth? So what I would say is that the baseline of really good supervision is understanding your supervisee. Because if we think about this, it's like concentric circles. If the supervisee at whatever level is providing support for the individual that we're serving in our community, and then the supervisor is going to hold that person, is going to understand that individual, whether it's a therapist or a counselor, within the context of their history, within an understanding of their own internal attachment system and life experiences and social cultural experiences. And so we hold that person, and then we hold the relationship, and we look at what's the exchange happening between these two people. Now, this can happen at all levels of education, right? We want to understand what's the relationship here. Where might the supervisee, whether it's a therapist or a counselor, be getting triggered by the individual? Where might they feel afraid? Where might they have a hard time regulating themselves? And then could the, and then how do we recognize how to support the supervisee so that they can better support the person that they're working with? And then sometimes it even goes another level where the supervisor seeks their own support, right? So that we have all these concentric circles of holding each other. And so, I would always start there, Katie, in terms of what does good supervision look like? And then beyond that, we want to understand what blocks us from being authentically present with the people that we're with. Where do we feel like we're going into applying a protocol versus being a therapist and a person first, right? So we start with our basic humanity, and then we build the skills of, how do you feel in your own body, and what happens for you when you're sitting in the room, and how might you guide the client into touching into a little bit of the trauma material safely, and then backing out and feeling grounded and not overwhelmed by the process. And so we can build skills of safely touch and go or pendulating between the trauma material and safety. Peter Levine, in his somatic experiencing model, calls this titration. And titration is a chemistry term. It's basically when you're mixing a acid and a base, like you're going to, again, create that volcano science project of your baking soda and your vinegar. But if you pour all the vinegar into a whole bunch of baking soda, you get a huge explosion. What we want to do here is take a dropper full, and we just put a few drops of the vinegar, and we let the bubbling up and the settling down. So when we drop a little bit of our attention toward the traumatic activation or the dysregulating emotion, and then we come back to a sense of feeling safe and grounded in the here and now, then we are, it's like we're just doing that little titration model. We just put a little bit in, we allow that to bubble up, we find what movements need to happen, what relational experience needs to happen that creates a sense of repair, and then we can repeat that cycle around again. Dee says, I'm guessing you're asking about the 18-hour training. It's through PESI, and it's recorded. So it's open to anyone that wants to take it, and you can find it on PESI. Katie writes, awesome body, mind, soul case conceptualization from Brilliant Minds model. It's a good resource. Thank you. And I don't know the Brilliant Minds model. Is that something out there? So let me know or put a reference into it. Or if you're just talking about our brilliant minds collectively here, that's cool too. So, all right. Let's see, we've got just a few more minutes if there's any final questions here. And really, I just want to thank you all for the opportunity. Is it a book? I'd like to know that book. That sounds great. Brilliant Sanity. Okay. Are you talking about Ed Podball's book? I'm so curious. And and I'm responding to Katie's text in here. So we are just coming to close. Yes, the Naropa Professors. This is Ed Podball's work. Fantastic. So just an absolute gift to be here with all of you. Thank you for your participation. And it looks like Chelsea's putting up the survey that you can do, and I'll open it back up.
Okay.
So. Good.
Thank you so much, everyone. Please do the survey, and thank you, Arielle, so much for everything that you've done.
Thank you. Absolute pleasure to be here. And thank you again, Katie, for inviting me. Really, that's such a treat. Good. Wonderful. I'm appreciating the comments coming in. People saying this is what I came here for. I loved it. I'm very grateful.
Great. Thank you so much, Tamra and Arielle. If we're all good, I'll direct us again to the chat to access an evaluation survey. And otherwise, I'll let me know when you're ready for me to close this out.
Okay. Thank you. Thank you, Andrea. That's lovely. I'm glad you enjoyed the webinar.
All right, any last comments before we move into our days? All right.
Okay. Thank you. I'm all set.
Wonderful. Thank you. Thank you, everybody.
Thank you. Thank you.